Okay, everybody. Once again, I'd like to thank the panel and everyone for inviting me, and also for those of you who are listening. I'm going to talk about when can we use combination therapy for our pediatric IBD question, or rather, questions about combination therapy for our pediatric IBD patients. Here are my disclosures from the last 12 months. And here are the questions that I really came up with while I was trying to put together this talk. Number one is, should we use combination therapy in our pediatric IBD patients? If so, what kind? Should we use thiopurines and anti-TNF, methotrexate and anti-TNF? How does monitoring of levels of biologics, therapeutic drug monitoring, impact in our decision? Is adalimumab different from infliximab in terms of its immunogenicity? Should we approach that one differently? And then also, how long do we continue combination therapy? I would encourage all of you who are kind of struggling with this issue as I am to read this particular review, and you can email me, I'll forward it to you. Basically, it's called Loss of Response to Biologics versus Increased Risk of Lymphoma in Children with IBD, the Clinician's Conundrum. And just to quote one sentence, currently combination biologic and immunomodulator therapy for moderate to severe Crohn's is the most effective treatment regimen. However, the clinician's conundrum arises from recent understanding that rare but serious adverse events do occur with the use of these strong immune suppressive drugs and may be more prevalent with combination therapy. In other words, it gets once again to this slide I showed yesterday, controlling the disease versus minimizing medication side effects. So let's talk about biologics, and let's assuming you're going to start one, either right out of the box or because your other agents, immunomodulators, haven't worked. So what are your options right now? And there may be other ones, but these are the ones I covered. Monotherapy with infliximab. The pro is that it works, but the con is a significant number of patients may get antibodies and lose response. You can use infliximab with levels, and that may work better, but I don't think there's convincing data yet that it reduces antibody formation. Adalimumab monotherapy also works, but once again, you run the risk of antibodies. You can use combination therapy with azathioprine and infliximab, for example. That works the best. It may reduce antibody formation, but you've got the big con, as Bob described eloquently yesterday, of the increased risk of lymphoma. And you can use combination treatment with methotrexate and infliximab. Works, might reduce the antibody, but the issue is it might not be better than monotherapy for anything. So I tried to read all the literature on biologics, antibodies, loss of response, and drug levels for this talk, and what I got was one big Rorschach blot, in other words, data that can be interpreted in many ways. So my caveat today is this is my interpretation. You should read these papers yourself, as Bob said yesterday, and make your own interpretation of the literature. Don't just let the experts tell you what they believe, because we're not any smarter than the people in the audience. I'm going to start with adult studies first. So let's first look at combination therapy in both Crohn's and ulcerative colitis. This is adult data, and I'm going to focus on remission rates. SONIC, I think you all know about from 2010. It was a Crohn's study where patients were randomized to azathioprine and infliximab with the best outcome. Infliximab alone was better than thiopurine, but if you looked at the antibody level, it was only 1% in the combination group versus 15% in the monotherapy group. A recent study just published in Gastroenterology the last couple months, which I'm going to go into in more detail, is a study done from Remo Panaccione and colleagues in Canada and Belgium and other areas called UC Success. Basically a very similar study design, only with active UC. And once again, look what you see in terms of 16-week, again, a short-term study, remission rates. Azathioprine and infliximab together, 40%. Infliximab alone, 22%. Azathioprine alone, 23%. And once again, antibodies to infliximab, 3% in the combo group, 19% in the infliximab monotherapy group. So let's look at this study in a little bit more detail because it's important and it may be new to most of you. 239 adult patients randomized to azathioprine, standard dose, infliximab, standard kind of 0, 2, and 6 weeks, then every 8 weeks, azathioprine and infliximab together, and it was a double-blind, double-dummy design. That means adults got sham infliximab infusions or sham 6-MP if they were randomized to placebo. The inclusion criteria, while moderate to severe UC, stable dose of steroids was allowed in, no prior treatment with methotrexate, cyclosporin, Tacro, or rectal therapy, and you had to have been azathioprine naive for 3 months or more. So the first thing I want to show you, if you look at this study, is there were a fair number of dropouts. In other words, a lot of patients did not make it to the 16-week period. People withdrew because they either had an adverse event, they withdrew consent, meaning they wanted to, probably drop out of the study, non-compliant, or some mistakes were made in enrollment. So you had about a 25% dropout rate in this study. If you look at the results again, so again, I repeated the remission rates and I showed them before, but the other interesting thing, if you look, was the drop in the Mayo score. Azathioprine alone had a drop in the Mayo score of 3, which is pretty good. If you go from 6 to 3, that's fairly significant. But infliximab was even better, and once again, the combination was the best treatment. So the calprotectin levels were lower in the combination group. So these all came in with high calprotectins, and when you looked at the end of the study, in the combination group, it was 170 compared to around 400 in the other two groups. And I think this is important. Basically, these were the drops in the levels at the end of the study. So keep that in mind, that basically you are maybe doing a better job of controlling the disease. Serious adverse events, interestingly, were largely due to azathioprine. They really had more in the azathioprine groups, primarily pancreatitis, anemia, nausea, or vomiting. They did not assay 6-MP, do levels, or do TPMT, which is interesting. So, of course, you may have more problems with that. So, should you think about using combination therapy on your UC group? To be honest, I'm not there yet, but if you're looking at the most effective treatment, it's something that might be considered, maybe even short term. Now, let's look at loss of response in the natural history. This is in Crohn's and colitis bunched together, a study from Bill Sanborn, and they took a group of patients that was treated with combination therapy, azathioprine and infliximab for at least 6 months at the discretion of their physician. And azathioprine was actually withdrawn by their physicians, presumably because of concerns about lymphoma in about half the patients. And then they defined loss of response as increasing the dose, shortening the interval, surgery, hypersensitivity. And the scary number here is about 40% lost response between 24 and 32 months. And withdrawal of azathioprine was strongly associated with infliximab failure. And this is really interesting. Now, I will say, I didn't have time to put this in, but a very recent study done by Van Asch et al. Out of Belgium, which is a follow-up of another study, actually came up with an opposite result, that withdrawal of azathioprine does not necessarily increase loss of response. So read both those studies, not just this one. So what about methotrexate, as I think we started to talk about yesterday? The best study in adults was the COMMIT trial recently by Brian Fagan and colleagues. It was a 1 year, 50-week trial in adults with Crohn's. 126 patients were randomized to either monotherapy with infliximab or infliximab and methotrexate. Now keep in mind, this is moderate to high dose methotrexate, subcutaneous up to 25 milligram per week, higher than many of us use in our low-dose methotrexate regimens. So the primary endpoint, if you look at the top survival curve on the right, was lack of steroid-free remission at week 14 or at 50 weeks in dropout, and there was identical failure rate in both groups. However, antibodies were lower in the infliximab and methotrexate group, 4% in the combination group, and 20% in the monotherapy group. So in this regimen, outcomes were not changed, but antibody levels were reduced. Now, what about adalimumab and development of antibodies to adalimumab? Again, a very, very confusing paper that just came out. It's in press because of the way they defined loss of response, but a large multi-center study coming out of Israel. And this included both adult and pediatric patients, 247 of them. And what was interesting was they defined not loss of response by patient, but by event. And the events could include suspected worsening by the physician or, quote, definite inflammatory loss of response with the identification of inflammation by labs, stool markers, and or endoscopy. And what they noted is of 142, quote, loss of response events, whatever that may mean, 38% were associated with antibodies. And it was unclear in this study whether immunomodulators affected outcome. However, the description of anti-adalimumab antibodies more than 4 mic per ml, or positive antibodies, predicted patients who did not respond to increased doses of adalimumab. That should be adalimumab, not immunomodulators. So now let's move on to pediatric studies. And to summarize the adult ones, combination therapy with azathioprine and infliximab and others, more effective, lower antibody rate, but perhaps greater risk, what I said yesterday. Now, moving to peds, this is a classic landmark study by Jeff Hyams and his group, the REACH trial. Basically, they gave standard infliximab infusion 0 to 6 weeks, then every 2 months, 88% response rate after 3 infusions, and a very nice remission rate after 12 months. However, concomitant immune modulators were used in almost all these patients for the duration of the study, and take home that REACH describes the efficacy of combination therapy, the majority of which were treated with thiopurines. Look at the date, 2007. Patients were enrolled before the scare came out about hepatosplenic T-cell lymphoma. Now, in our population, we are all over the map. Most of our patients are not on combination therapy. Some are on methotrexate and infliximab. Some are on infliximab monotherapy. So we just went to our infusion center. This study is in press. Namazit Amersky, the first author, is lower right. And it was a cross-sectional cohort of 133 children in our infusion center, all still receiving infliximab. In other words, their docs thought it worked. 20% had antibodies to infliximab. And what we found, if you look at this study, on the x-axis is your antibodies to infliximab, and on your y-axis is your infliximab level. I don't have a pointer to highlight, but you can look at it yourself. As your antibodies go up, the likelihood of your level going down is very high. But these patients were still all okay getting their medicine on in the infusion center. So what does this mean? To me, it means there may be a latency period between the development of antibodies, the drop in the levels may occur after that, and loss of response may occur a year out, for example, because we know even if you stop infliximab, it might take a while for your Crohn's to come back. Another study by Marla Dubinsky showed kind of what happens over time with patients on pediatric infliximab. And you can see here again, loss of response, a major issue. They had 188 patients on Remicade for at least 1 year with a median duration of 29 months. And the results were approximately half lost response. In other words, they underwent dose intensification to maintain or recapture remission, though about 70% of patients ended up staying on infliximab. Here they looked at low-dose oral methotrexate, did not find a difference. But again, the dose, the compliance, all these things were not monitored. So Marla's taken an interesting approach to look at this issue, and she started measuring levels at week 14. In other words, prior to your 4th dose of infliximab. And what she was able to show in this study recently is that the higher your level at week 14, and you can look at this over on the right, the more likely you were to have a remission after a year. So most of these patients were on monotherapy. Some were on immunomodulators, and they really didn't find, though there was a fairly small study, to show that immunomodulators correlated with outcomes. And once again, look at that antibody rate. 26% with antibodies to infliximab by week 54, almost identically in what we found in Namazit-Amersky's study in Boston. What about adalimumab? Well, again, for the interest of time, I'm going to just quickly zip through these slides, but the key point is, with this study, adalimumab works great if you've never seen infliximab. However, if you're an infliximab failure or you've switched over, your long-term remission rates in yellow there are about 20%, which is really kind of scary, which is why you want your first biologic to last. And interestingly, in this study, antibodies to adalimumab were only about 3% after 1 year, very different from that Israeli study. So to summarize, and then I'm going to go into how I practice, there's good evidence that using combination treatment with thiopurines in patients starting on infliximab anyway improves remission rates in Crohn's and UC and reduces the likelihood of antibody formation. Data on combination therapy with methotrexate and infliximab is lacking as far as efficacy. It may reduce antibody formation, but we desperately need more studies. And it's unclear to me from reading the literature if combination treatment impacts antibody development and clinical outcomes in patients treated with adalimumab. In other words, adalimumab and infliximab may be different. Once again, more studies are needed. So looking at this, here's how I like to practice. I treat my moderate Crohn's patients with an immune modulator first, usually, if it's not too bad, then a biologic within about 6 months if there's been no or a poor response. I usually continue combination treatment, meaning azathioprine and infliximab, for about 6 months, but I'm always trying, because of the concerns Dr. Baldessano raised yesterday about long-term thiopurine therapy, to replace the thiopurine with low-dose methotrexate. Some of my patients refuse the thiopurine because of the lymphoma risk, in which case I'll use methotrexate or infliximab first. There's a group of patients, however, high risk or severe Crohn's, that I treat with combination therapy if parents will let me, or with monotherapy. This is extensive disease patients, especially mid-small bowel, severe rectal or perianal disease, steroid unresponsive disease, or patients with bad growth failure, especially if it's mid to late puberty. And patient preference is very important in making these decisions. So I want to close with one additional slide about a trial that we're hoping is going to get funded through the Improved Care Now network, and Mike Kappelman is the lead on this study. And in essence, what we're hoping to do to look at the methotrexate question in more detail is to randomize children that are starting with anti-TNF treatment and have no contraindication of methotrexate use to either anti-TNF and placebo or anti-TNF and methotrexate. And we're going to follow these patients out for 2 years. We're going to look at steroid-free remission, adverse events, patient-reported outcomes, and antibodies to TNF. And my ideal world, methotrexate works. It reduces loss of response. It's well tolerated with patients. It reduces antibody formation. And now we have a regimen that I'm hoping is both proven effective and acceptable to everybody, validating what many of us are doing in practice. But again, there's no proof that it works. So once again, thank you for your time. And here's our group in Boston. Thank you.